The next lecture we have two speakers, Dr. Banan Ateeq and Dr. Nour Jafal, graduated doctors from Al-Quds University, Al-Maqasid Hospital, Palestine. Please, go ahead.
Good evening, everyone. My name is Dr. Banan Ateeq. I'm a graduate doctor from Al-Quds University, and this is my colleague, Dr. Nour. We're going to talk today about clinical spectrum and management challenges, a case series of 11 Palestinian patients with Hyper-IgD syndrome. So first we'll talk about the disease in general, and then we'll proceed to talk about the patients. Hyper-IgD syndrome is a rare autosomal recessive autoinflammatory disorder affecting 1 in 50,000 to 1 in 5,000 patients. Most reported cases are among individuals of Western European descent, mostly in Netherlands and France. Hyper-IgD syndrome is often misdiagnosed, leading to inappropriate treatment and increased patient morbidity. This study is the first comprehensive case series of Palestinian patients with genetically confirmed Hyper-IgD syndrome. We aim to describe the clinical and genetic profiles of Palestinian Hyper-IgD syndrome patients and highlight the diagnostic and treatment challenges in a resource-limited setting. So first we'll talk about the pathophysiology. There is no one clear pathophysiologic mechanism that explains Hyper-IgD syndrome, but one of the most important theories that are suggested is that MVK gene mutation causes reduced activity of mevalonate kinase enzyme and accumulation of mevalonic acid and decreased production of isoprenoid products. This causes inflammasome activation and overproduction of IL-1 beta, and as a result, systemic inflammation. So Hyper-IgD is the mildest form of mevalonate kinase deficiency, while the most severe form is called mevalonic aciduria that causes early infancy death. So Hyper-IgD is characterized by recurrent attacks of fever recurring every 2 to 12 weeks, mostly 4 to 6 weeks, and lasting 3 to 7 days. The clinical manifestations include general weakness, fever, headache, mucocutaneous involvement in 80% of the patients in form of maculopapular rash, urticarial rash, purpura, erythema nodosum, oral ulcers, or genital ulcers. Joints affecting 80%, involving 80% of the patients in form of large joint arthritis. Lymphoid tissue is involved in 90% of the cases in case of cervical lymphadenopathy or generalized lymphadenopathy. Splenomegaly is seen in 50% of the cases. Gastrointestinal symptoms like vomiting and diarrhea in 70% of the cases, abdominal pain in 85%, hepatomegaly, serositis, abdominal adhesions. And regarding the biomarkers, acute inflammatory markers are elevated during the attacks. IgD levels are elevated more than 100 international units per ml during the attacks, while there is a concurrent elevation of IgA in 64 up to 80% of the patients. Urine organic acids are also elevated due to mevalonic acid accumulation. Vaccines, minor trauma, stress, or surgery can trigger an attack, and complications include amyloidosis in less than 3% of the patients, and to a less extent, macrophage activation syndrome. So this is a retrospective case series conducted between 2017 to 2025 at Al-Maqasid Hospital in Jerusalem. We included 11 patients genetically confirmed to have Hyper-IgD, aged less than 18 years. Data collected in retrospective manner from hospital medical records and included demographics, triggers, clinical features, lab results, genetic findings, and treatments and responses. So we have a small sample size, 11 patients. We have 7 females, 4 males. Six of our patients had parents that are first cousins. 7 of our patients had a positive family history of periodic fevers, and geographically, 5 of our patients were from Jerusalem, 2 from Hebron, 2 from Ramallah, and 2 from Gaza. The median age at onset was 5 months and ranging between birth to 5 years. The median diagnostic delay was 2 years and ranged from 25 days up to 5 years. So viral infections triggered attacks in 11 of our patients, in all of them. Vaccination triggered attacks in 3 of our patients, and stress or exertion triggered attacks in 1 patient. So the core clinical features include fever observed in all of our patients up to 42 degrees, lymphadenopathy, mostly cervical, tender and reversible in 9 patients, and in 1 patient it was generalized and resolved with treatment. Splenomegaly was observed in 8 patients, and it was persistent between flares. GI symptoms like abdominal pain and diarrhea in 6 patients, vomiting in 7 patients, cholestatic jaundice in only 1 patient. Arthritis of large joints were observed in 5 patients. Skin rash was observed in 3 patients in form of maculopapular and urticarial rash. So regarding the lab findings of our patients, all of them had leukocytosis with increased inflammatory markers, CRP and ESR, during the attacks, which normalized in between attacks. One exception is that patients with persistent arthritis had persistently elevated inflammatory markers prior to treatment. IgD level was not tested except for 1 patient, which is a missed opportunity due to its relevance to the disease, but it was costly and unavailable. IgA level was high in 5 of our patients. Serum amyloid A was tested in 3 patients, all normal. Urine organic acids during episodes was also tested in 9 patients, and it was normal in all of them. So regarding the genetic profile of our patients, all of them had MVK mutations. Most were diagnosed by targeted MVK gene testing, 9, and 2 by whole exome sequencing. The most common mutation was the missense mutation p-valine 377 isoleucine in exon 11, found in 6 patients, and it was associated with mild hyper-IgD syndrome. Overlap syndromes was observed in 2 patients who had concurrent MEFV gene mutation, and so 2 autoinflammatory diseases at the same time. So now I'll leave you with Dr. Nour.
Assalamu alaikum. I will discuss the results and complications noted in our patients. So treatment responses to various modalities were variable, reflecting the broad spectrum of the disease and the challenges in management within our setting. NSAIDs and steroids were first-line mainstays in disease control in all patients. 7 out of 11 of our patients are currently managed with NSAIDs and steroids, showing satisfactory control of attacks frequency and severity. Colchicine was used in 5 patients. None of them showed improvement except for the patient who had FMF overlap. One of our patients was treated with a TNF inhibitor in April without showing a significant improvement and was shifted to anakinra with satisfactory response. Anakinra was started in 4 of our patients, one of them who had symptoms and manifestations of the disease since birth. Another had a complicated course manifested by macrophage activation syndrome, and another one had a severe manifestations while being treated with Actimra and was shifted to anakinra. Complications were noted as delayed diagnosis and mismanagement of our patients. Failure to thrive was noted in 3 patients. One of them had severe failure to thrive and due to chronic steroid use. 2 of the patients showed growth catch-up to their age. Macrophage activation syndrome was noted in 2 patients. Amyloidosis, fortunately, was not noted in any patient. Our case series illustrates the remarkable clinical heterogeneity of hyper-IgD syndrome, even among individuals sharing the identical MVK mutations. The phenotypic spectrum ranged from mild clinical periodic fevers with lymphadenopathy to severe life-threatening manifestations mimicking HLA picture or systemic GIA. All the atypical cases demonstrated complete dependence on interleukin inhibitors, but unfortunately, the interleukin inhibitors like anakinra remain inaccessible due to non-coverage by the national health programs, which places unsustainable financial burden on the families and exposes patients to preventable morbidity. A special presentation noted in our patients that two affected siblings, a female and her brother, was diagnosed to have Hyper-IgD syndrome. The female patient exhibited severe presentation at the age of 2 months, manifested at persistent cholestatic jaundice, hepatosplenomegaly, and elevated liver enzymes. She later on developed metabolic acidosis and hyperammonemia, while her brother presented with monoarthritis of swelling of his left elbow and lymphadenopathy without metabolic or hepatic involvement. This intrafamilial variability reflects that the Hyper-IgD syndrome has variable broad clinical spectrum, and even identical mutations can present with different clinical presentations. Another patient. Okay. بس أحكي بس عن the presentations. Another patient who had a severe presentation manifesting as upper GI bleeding, developed macrophage activation syndrome-like picture, and developed systemic inflammation with chronic anemia and oral ulcers and interstitial lung disease. He was treated with anakinra and showed a good response. The challenges in diagnosis and management manifest as the delayed diagnosis due to the low threshold of suspicion of the disease and restricted access to genetic testing and effective biological therapies. To conclude, Hyper-IgD syndrome remains a diagnostic challenge in our area due to the low disease awareness and limited resources. Patients show both typical and atypical presentation. Genetic testing is essential to diagnose the disease. The normal levels of Hyper-IgD and urine organic acid does not rule out the disease. The best treatment was in our patient is by interleukin-1 inhibitors that significantly improved the quality of life, but was not available. To conclude, we say that behind all these numbers, there is always a call of action, and behind every case lies a journey of uncertainty, delays, and resilience. And it's time to change the story. Thank you.